Radial nerve. For examination, look for wrist drop, thumb held in adduction, tricep and forearm wasting. Compare on the other side, look for splint, look for scars, feel for sensation in the first dorsal web space. In high injury, tricep is involved. Low injury, the pin is involved, in which the EPL is affected and EDC is affected. That is, finger extension is affected. Radial nerve anatomy originate from the posterior cord C5 to C8, run in the posterior wall of the axilla, runs through triangular interval with profunda brachii artery between long head of tricep and humerus, courses through the spiral groove between lateral and the medial head of tricep, passes through lateral intermuscular septum 7.5 centimeter above the lateral lateral epicondyle, run in the interior and lateral aspect at cubital fossa, runs between brachialis and brachioradialis, passes between two heads of supinator, divides into superficial and posterior interosseous nerve. The sensory branch to the dorsal radial aspect of the hand supplies 3.5 digits. The posterior interosseous nerve originate at the radiocapitellar joint, divide under supinator edge, superior edge of supinator, passes between the two head of supinator, reach posteriorly interosseous membrane of the forearm, reaches fourth extensor compartment, supply the dorsal wrist capsule. The pin supplies all dorsal compartment muscles except ECRL. The muscles which are supplied by pin are EDC, EDM, ECU, EIP, EPL, EPB, abductor pollicis longus, supinator, and ECRB. ECRL is supplied by the radial nerve. Cause of pin palsy: FREAS, F-R-E-A-S, fibrous tendinous band at origin of supinator, 30% of people. Radial recurrent vessels, that is leash of Henry, extensor carpi radialis brevis, arcade of Frosch, that is proximal edge of superficial head of supinator, and supinator distal border. Rheumatoid arthritis can affect it, dislocation of elbow on tibia fracture, surgical resection of radial head, and mass lesions. Presentation of pin palsy: pin compression, pain, and paresis, tenderness distal to the lateral epicondyle, inability to extend finger and thumb, can do the wrist extension with radial deviation as ECRL is working but ECU is not, increased pain on resisted supination. Tenodesis test used to differentiate from extensor tendon rupture due to rheumatoid arthritis. Treatment: rest and activity modification, lidocaine and corticosteroid injection. Surgical decompression is a last resort. Radial tunnel syndrome: there is pain but no paresis, mild compression of posterior interosseous nerve without paresis, symptom dull ache in the extensor muscles, worse at the end of the day, sign is local tenderness 5 cm distal to the lateral epicondyle, pain elicited by resistive active supination. Each finger is tested under resisted extension. Testing the middle finger increases the pain due to ECRB. Insert on the base of the third metacarpal. Model A test. Similar like tennis elbow. Firm pressure is applied by the examiner at the dorsum of the proximal phalanx of the middle finger. Differential diagnosis, tennis elbow. Investigation, nerve conduction studies. Increased motor latency in active forceful supination. Management is conservative, anti-inflammatories, avoiding provocative test, surgical decompression by Thompson approach between ECRP and EDL developed, pin found just proximal to the arcade of Roche. Waterburn site, wrist watches causing neuropathy of the superficial radial nerve. It's a compressive neuropathy. Sensory band emerges between the brachioradialis and ECRL, 5 to 8 centimeter proximal to the radial styloid. Only sensory manifestation. Provocation test is wrist flexion and ulnar deviation. This stretches the nerve. Treatment is symptomatic. Surgical steroid injection. Surgical decompression is possible through anterior approach, Henry, distal to the tinal sign, distal to the site of the tinal sign.